So when I was in Washington State, I participated in a study where we had 46 community pharmacies across the state treating minor ailments in the community pharmacies. And UTIs were the most popular by far, right? And what we found with that study was that the outcomes were the same, whether they got treated at the urgent care, the emergency department, or at the pharmacy, right? So same care, same outcomes, right? And the cost was $277 less per episode on average. And
if they got it at the pharmacy.
Yeah, exactly. So besides those outstanding results, the number one thing that really stuck with me in those conversations with those patients is that they said, oh my gosh, this is amazing. I didn't have to take a day off work. I didn't have to drive an hour to the nearest urgent care. And that is the value, real value, I think, for Alaskans.
Welcome to the East Anchorage Book Club. I'm your host, Andrew Gray. The purpose of this podcast is to tell the stories of Alaskans of interest and importance. Today, our guest is the Executive Director of the Alaska Pharmacy Association, Dr. Brandy Seignemartin. After a circuitous route, Brandy found herself in pharmacy school in her early 30s. After completing her doctorate degree, she did an executive fellowship in administration, and in 2022 came to Alaska to take on the ED role at the Alaska Pharmacy Association and to become an assistant clinical professor at the University of Alaska Anchorage Idaho State University Doctor of Pharmacy program. We discuss House Bill 195 today, which is sponsored by Representative Genevieve Mina and would grant limited prescriptive authority to pharmacists in Alaska. Full disclosure, I am a co-sponsor of that bill. Dr. Brandy Seignemartin, welcome to the podcast.
Thank you so much. It's great to be here.
Tell us about your early life.
Yeah, I grew up in southern Utah, St. George, a beautiful Red Rock area with my family. I'm the oldest of 5 kids, so, always the one taking care of
Latter-day Saints?
Kids. I did grow up LDS. I sins of no more. But grew up there with my family. I loved it. It was great. After I graduated from high school, I obviously have an adventurous spirit. I moved to Hawaii and lived there for a few years before coming back, and then made my way to Washington State.
Let's stop.
Yeah.
Were there pharmacists in your family?
No, there weren't. And I was a non-traditional student. I didn't even start at university until I was 28 years old.
28?
Yes.
Was when you started your undergrad?
Yes.
Okay.
And I'll tell you, when I came out, my parents disowned me. I couldn't even go to college because I could not fill out my FAFSA. They wouldn't give me the information that would be required to even get financial aid to go to college. So I had to wait until I was old enough that I did not need my parents' information.
Got it. So you graduated from, did you come out in high school?
No, when I was early 20s.
Early 20s.
Yeah.
So, I'm sorry, we rushed through it so fast.
Okay.
You graduated from high school and moved to Hawaii?
Yeah.
Okay. By yourself?
Yes.
Gotcha. And so you had some years to sow your wild oats and find yourself on your own in Hawaii.
Exactly. And then I came back to Utah, and then I came out, and then got disconnected from my family for a while, and ended up moving to Washington State and lived there actually for quite a long time, which I liked it there.
And then went to undergrad at?
So I met my now wife in Spokane, Washington. She was born and raised there. And she was studying anthropology. And the University of New Mexico has this most amazing anthropology program. So we went to the University of New Mexico for her to finish up her degree there. And that's where I actually started my education in January of 2012, which was a really exciting time. And what's really cool is what she got to do there. She got to study prehistoric human remains that had never been looked at before or analyzed as part of her training, which was super interesting. So I started my training there, and then we made our way back to Washington State. And I went to Washington State University, finished my undergrad. I was actually originally, my path was towards engineering, because when I started university at 28 years old, I hadn't done any kinds of math in so long, right? So I started in what I call the kiddie pool math class, and I loved it. I spent so much time doing math. I got 100% on all of my tests and stuff, and was like, oh, this is really cool. Maybe I want to be an engineer because I like solving problems. So I started down that path, and then I had at Washington State University, one of my professors, we were doing a project, and my project was actually more about pharmacy kind of topics. And so the professor took me aside and said, hey, have you ever thought about going into pharmacy? And I was like, no, I actually haven't. So I walked across the street to the library, started researching, what do pharmacists do? What are, the kinds of different jobs for pharmacists and that kind of stuff. And I was like, oh, this is really cool. So went home and talked to my now wife, and it was would you support me in going to 4 more years of university? And she said, absolutely. That's great. So I applied for pharmacy school.
Was she working as an anthropologist?
She was not. She was actually working in financial aid at Washington State University. So she's done a lot of work in higher education and healthcare administration, and those kinds of things.
But it seems like she'd also have sort of like the inside track on here's how we're going to make this as affordable as possible.
Yes, absolutely. So she supported me through that, which was great. The funny thing was, so then I started in pharmacy. I really wanted to be a community pharmacist. I love working in community pharmacy. I love the tangibility of being able to help someone who's right in front of you and know that you're making a difference in their life. And that's just absolutely one of the most rewarding things for me. So started down that path, worked in community pharmacy, but then I went to my first legislative day, actually as a first-year pharmacy student. And we advocated on a bill about like drug take-back bins in pharmacies to get
in Olympia.
Yeah, yep. Exactly, in Olympia, Washington, to have receptacles so that people have medications like dangerous opioids or something that you don't want to have at home. You can go dispose of them essentially. And that bill passed later in the legislative session, and it totally sparked me. I was like, oh my gosh, this is amazing! Like, it's not just changing this one person's life who's right in front of me. I realized like these systems of how we practice and like how we do healthcare, they've been built, they can be rebuilt. And by engaging in like this level of advocacy in healthcare, we can actually change the system and improve how people access their healthcare, which is, exactly actually why we're here talking about this today, right? Mm-hmm. And what pharmacists can do in that system. So I actually ended up getting into student government for our Associated Students of Washington State University Health Sciences. I was the vice president of legislative affairs, and I led the passage of a piece of legislation that allowed for interprofessional precepting between nursing, pharmacy, and medicine, because as students, we wanted to do all these health fairs in the community. And sometimes, what sparked it was actually one day we had a health fair planned, and the nursing faculty was sick who was going to be precepting the nursing students, and she couldn't come. And the nursing students were so bummed because now they're missing out on this opportunity, and like we were all bummed, right? So we said, this is obviously something that needs to get changed. So luckily I had some amazing mentors who helped support me through that, but got to go testify in committee and work with all of the professional associations, the nurses and the physicians and the pharmacists, and really work through that stakeholdering process, and just got to develop my advocacy skills in that space and was so excited about it. And it kind of took me on this other path where I still worked in community pharmacy, but I decided to do an executive fellowship in association management after I got my doctorate of pharmacy degree. So I did that at the Washington State Pharmacy Association, and then stayed on there working for a while as the director of policy and practice. And I also actually practiced one day a week at an independent community pharmacy, where we had some really interesting opportunities during COVID to actually transform at that time what we were doing in the pharmacy, which was great and exciting, and lots of good overlap between what we were doing at the association to support pharmacies in rolling out additional services, and also doing them in practice at the pharmacy was very beneficial too. Then we actually came on a family vacation with my wife's whole family to Alaska. After COVID, we were like, we need a big vacation. And we all voted, is it going to be Hawaii or is it going to be Alaska? And 6 of the 8 of us selected Alaska, and we had never been here before. So came, stayed for a week in Eagle River at a house, and we just had the most amazing time. And it was obviously so beautiful. And instantly my brother and sister-in-law said, oh my gosh, we can't wait to move here. As my wife tells it, they said, we're going to sell our kids, we're going to sell our house, sell our cars, and move to Alaska. And we both said, we love it here, but I didn't think in my area of kind of expertise in pharmacy, I didn't know that there would be a role for me here, because a lot of smaller associations, they can't have like a pharmacist working for them essentially. However, 3 months later, this position became available. And what they had done was they had never had a pharmacist in this role before, but they partnered with the university, the Doctor of Pharmacy program that is 10 years old this year, and said, hey, what if we had a shared position, so this shared role, and we'll each be able to pay some into it to help support. So I actually have a very unique role where it's a 50-50 co-funded position between the UAA ISU Doctor of Pharmacy program and the Alaska Pharmacy Association. So my office is on campus. I get to work with students all the time, which I absolutely love. So my clinical appointment is actually as the executive director of the Alaska Pharmacy Association, and then I'm a clinical assistant professor. So I get to teach the students, I get to do scholarship, so I get to do that kind of work, and it's that really feeds me, and then it gets the students really involved in the association, and they're truly they're the next leaders of our profession of healthcare in Alaska. So it's really rewarding to get to do that work and work with them.
So you're the executive director of the Alaska Pharmacy Association?
Correct. Yeah.
And you've been in the role since 2022?
Since February 2022. So X is I think is my 4-year anniversary.
And what's the experience been like? What's it been like living in Alaska and doing this job?
Oh, it's amazing. It is so amazing. It's so rewarding. First of all, I love Alaska. And one of my goal the very first year here was to try to really get around the state, to really have all the Alaska experiences. Because one of the things that I noticed being an outsider, the biggest challenge that I had was there's a lot of suspicion among Alaskans for outsiders, right? So being the new kid on the block, I had to quickly get up to speed on Alaska and get out to the communities and understand what they look like. So when I'm out talking to pharmacists, when I'm out talking to people, I know what they're talking about. I can speak the language and that kind of thing. So, after that first year, I felt like I really got accepted into the pharmacy community and built some amazing relationships. One of the things I love about working in Alaska is that we have such a tight-knit pharmacy community. Our pharmacists and technicians, we're friends all the way across the state. We meet together regularly, and we just have such great camaraderie. And actually, we just found out that so the Alaska Pharmacy Association, the Alaska Board of Pharmacy, and the UAA ISU Doctor of Pharmacy program, the three of us, as we call in the profession, the triad, right? These three kind of main organizations that work together in pharmacy. We are going to be honored later this year with an American Society of Health Systems Pharmacy Champion Award for the collaborative nature of our work. That it just exemplifies how we all work together, rowing our profession in the same direction. So it's really a huge honor. And I think that exemplifies how we all work together. And it's really, really amazing.
How many pharmacists do we have in Alaska?
Around 500, according to the BLS data. It's really hard at the licensure level to actually track specifically because a lot of the pharmacists who work in the federal system, which is, probably close to 50% of healthcare in Alaska, they don't have to be licensed. Yeah. So that's pretty challenging to track specifically, but that's federal data.
Well, I'm glad you brought that up because I worked in the federal system before I ran for office, and I'll just share a little bit about my experience with pharmacists, and then we can talk specifically about some issues with Alaska that need to be fixed. So I went to physician assistant school at Baylor College of Medicine in Houston. My internal medicine rotation was at the Houston VA, and that internal medicine rotation was 2 med students, the PA student, me, and the PharmD student.
Wonderful.
And we all rounded together. We all saw the patients together. We all wrote notes on the patient. So my experience of what pharmacists do is absolutely informed by the fact that I went to school with pharmacists. I know that they are thinking about what the diagnosis is and what the best treatment is in the same way that I do, in the same way that the med students do, in the same way that physicians do. And so I have this very different idea of what a pharmacist does. And then I went on to work in the VA system where we had clinical pharmacists with prescriptive authority, and they were the greatest blessing of my time working in primary care. The clinical pharmacists, I was practicing medicine at a time with an explosion in new drugs, especially for diabetes. And so it was really hard for me to stay on top of what is the gold standard right now.
Absolutely.
What's the best regimen for these folks' first-time diagnosis for type 2 diabetes? And so what do? Just refer them to the clinical pharmacist. The clinical pharmacist starts their regimen. They evaluate the patient. They decide what the best regimen is for them. They prescribe it. They follow up. They make adjustments. And it was just, I could just worry about high blood pressure. I could worry about the things that I was good at and leave this area to them. And then, at a certain point, they don't need the clinical pharmacist anymore. I could just continue the regimen. It's working well. I can call the clinical pharmacist if I need them. It was shocking to me. Absolutely. I was just dumbfounded that outside of the federal system, pharmacists in Alaska had no prescriptive authority.
Yes.
So can you speak about your experience having worked in Washington?
Yes, absolutely. And actually, I'll speak really quick to the VA. So one of our first year student pharmacists He was in the military previously. He's from a military family, so always gotten his care at the VA. He comes to pharmacy school and he realizes, as we're talking about this legislation, and he's like, wait, you mean pharmacists can't do this stuff? I thought that they could because I've always been going to the VA to get my care. So super interesting, that difference. And so we know it's a proven model. We know that pharmacists can do it. In Washington state, actually, pharmacists have very broad collaborative drug therapy agreements. So they do not yet have independent prescription authority.
Interesting. I didn't know that.
However, there are many states that do. So Idaho, who is our school is partly based in Idaho, right? So we have 3 campuses, 2 in Idaho, 1 in Alaska. So in Idaho, they've had full prescriptive authority for, I think, more than 8 years now. And it's going very well. They've been able to increase access to care very significantly. We know that the model is safe also. There's currently at least 5 states where pharmacists have kind of what we call full practice authority. So essentially the same level of authority that like a nurse practitioner does in Alaska, a fully independent mid-level provider essentially. And then there are many other states that have varying levels of prescriptive authority for pharmacists. And from being a legislator, like every state's a little bit different, right? How legislators put these kinds of things together.
I'll just say that I was spoiled by the federal system. I was spoiled by the federal system in that it's like basically a 50-state compact for just about every profession, and meaning you need a license in a state to practice in all 50 states, which is, again, things that seem normal, and then you get on the real world and you're like, what is going on? What I learned as a legislator is how there's a lot of internal warfare amongst the different medical providers. And I think they're fine with it. They're coming on the podcast soon. The family practice physicians, they actually wanted to talk to me about the pharmacy bill. So there is a bill to expand the practice of pharmacists in Alaska. There's a lot of leverage to move it forward because it's part of us getting federal money for the Rural Health Transformation Fund. And so I think, tell us what the bill is and what it does.
Yes, absolutely. So what the bill does is it allows pharmacists to have very limited prescriptive authority independently. And then it also opens up collaborative practice agreements to make those functional for pharmacists to participate in higher levels of care, where we really want to see in Alaska, for example, pharmacists being able to prescribe medication-assisted therapy for opioid use disorder. We currently have no pathway towards that. So I do know the physicians, I've heard from some other legislators that they've been in the building and kind of telling them they oppose our bill, unfortunately. And there is this tension.
Did they say they opposed it? Because that's not what they told me.
Okay, that's what I was told, but I don't know. So I think that the part they don't like is they don't like the word prescribe in there. Unfortunately, the Department of Law has said we have to have the word prescribe and administer in there. It's essential.
But again, in my experience, that makes perfect sense. That makes perfect sense because there's one group of people that absolutely knows what they're prescribing. It's the pharmacist.
Right. Absolutely. And, the challenge to this type of opposition or these concerns are that the American Medical Association, they have their number one advocacy campaign. They call Stop Scope Creep. And it's really protectionism, right? Mm-hmm. For their profession. And the problem is it's not good for Alaskans. It's not good for Alaska. In Alaska, we need providers to be working at the top of their education and training. And I will be quite honest, this bill does not even quite get us independently working at that top of our education and training, but it does close the gap. So it gets us a little bit closer. So it provides us with some limited independent authority. So with this, I think there's so many amazing opportunities with the Rural Health Transformation Program. And, the profession of pharmacy, I've been meeting with pharmacists and leaders across the state for these last few weeks and bringing everyone together. And pharmacists are ready to meet the moment and really ready to innovate around models of care that are going to increase access for Alaskans. So there's amazing. This is an incredible opportunity, and I really hope that we can get over some of the opposition.
I have some questions.
And move it forward.
In my experience at the VA, the clinical pharmacists could order their own labs. Would this bill allow you to order lab work?
So this bill does not address labs. However, that was there was a scoring rubric for each of the states as part of the Rural Health Transformation Notice of Funding Opportunity. And when we looked in there at Alaska, they scored us lower because we can't order and interpret labs. However, our Board of Pharmacy adopted a standard of care regulatory model 2 years ago now. And, what that basically says essentially is that if you're trying to decide if something's within your scope of practice, if you can do it, if it doesn't explicitly says that you cannot do it. And then if it is in your education and training, then you're pretty much good to go. So the problem is that it's not addressed anywhere at all. So when I read that, I thought, well, it seems like you actually can order interpret labs. So we took that to the Board of Pharmacy, and they're going to be clarifying that we are, in fact, able to do that, which is, it's imperative to do that to be able to monitor your drug therapy.
If somebody has poor kidney function, it pretty much changes everything.
Yeah, exactly.
The dosages, everything's changed. So, I mean, like, at the very least, you need to be able to order a creatinine. But
yeah, absolutely. So that will definitely be really important for doing the monitoring. Really, with this, like what I see is, so in 2022, we passed a bill, House Bill 145, that added a section of statute in the pharmacy statutes that's called Other Patient Care Services, that acknowledges that pharmacists provide other services besides dispensing medications. And so it outlines when a pharmacist can independently provide those services. So that's the section of law we're adding prescribe and administer to. As the Department of Law said, it's imperative to get that in there. But it already is like a pretty narrow lane. So it's for general health and wellness, for preventative care, for conditions that are minor and generally self-limiting, meaning that they would eventually resolve themselves on their own anyway. But if we give you something now, we can help make it faster. So a pink eye or something like that, right? Or has a CLIA waived test to guide diagnosis. And I know CLIA waived, everyone's like, what does that mean? But we all lived through COVID, so we did it. Those tests that you can do yourself, the FDA has essentially said they're simple enough that anyone can do them, essentially. So with that, the models that we see in states where they're able to do this, we're seeing at community pharmacies where you can do a test and treat for strep, flu, COVID, and those things.
Well, I think there's something a little bit condescending about that, being like, you know what we're going to do? Let pharmacists do tests that anyone could do.
Right. And then actually, that's one of the points of conversation that we've had with some of the physicians is that they are kind of opposed to that. They're like, well, there's so many of them out there.
So I will disclose what the family practice physicians spoke with me about. They said that they wanted to discriminate in the bill between retail pharmacists and clinical pharmacists.
Absolutely not. No.
And you know what was interesting is that I guess is there that delineation for pharmacists?
No.
I don't know what a retail I'd like to explain. I kind of know what they're thinking. They're thinking like a lot of folks, not just in Alaska, but all over the country, when they think of a pharmacist, they think when they go into Walgreens and there's somebody behind the counter who's like, here's your antibiotics. Like literally, like, counting pills and here you go. Right. And, and that's what they think the pharmacist does is they go and count the pills and put them in the bottle.
Yeah, and that's actually the pharmacy technicians who put the pills in the bottle. Or we also have a lot of technology now that can help us with that too. Pharmacists are doing drug utilization reviews. They're looking at your entire chart. They're making sure there's no drug-drug interactions, drug-food interactions, drug allergy interactions, all of these different things. So they're really looking at your whole profile. And so, I try really hard not to even use the term to differentiate clinical pharmacist, quote unquote, because all pharmacists are clinical by the nature of their work. They're all treating patients and taking care of patients. Yes, it looks a little bit different in a community pharmacy setting than in an inpatient setting or at a primary care clinic, but pharmacists are all trained to a doctorate level. And so when you get out of that training, pharmacists already have the education and training to do this. And honestly, ultimately, in order for us to be able to have the ability to innovate around this once-in-a-generation opportunity that we have with rural health, we have 5 years to get this done and make these services sustainable. It's in the community pharmacy is where we're going to see a lot of those opportunities. And those are the pharmacists that need to have this. It's very limited independent prescriptive authority so that we have the ability to roll out these new services and increase access to care for patients with minor ailments or things that are that. One thing, I was actually in some meetings last week. We were here for a legislative fly-in. We had 14 of our amazing Alaskan student pharmacists here walking around the Capitol with their white coats
including
on.
One from my district.
Right? Yes. They're so amazing. It's so energizing to be with them. And they're so excited about this because this is the future of their profession, right? But I had an opportunity to sit on a meeting with the district pharmacy manager for Fred Meyer. And he said, one of the things he shared is, let me share something super simple that I actually see quite often, is that a parent comes in with a prescription for their child for a nebulizer solution, but not a nebulizer. So currently, Now it causes so many problems and delays in care. They have to call the physician's office, and then they have to field that call and then get another prescription over. So it leads to delays in care, frustration for parents, all these different things. And he said, under this, it's highly likely I could just go ahead and take care of that, solve it in real time, take care of the patient right in front of me, and send them on their way so that they can go take care of their child. So, that's one of those things that's like so simple and actually saves us all time and money. And why, again, it's so imperative that the community pharmacists have this level of authority.
So at the Alaska VA, we knew in primary care that there were psychiatrists doing very abnormal prescribing practices. And I reported it. When a 28-year-old goes in for anxiety and comes out with a prescription for 320 tabs of Xanax, it's just like insanity beyond insanity.
That's so inappropriate.
It was actually the pharmacist's repeated reports that led to psychiatrists being let go because, we had really cracked down on overprescription of opioids. And at least in that particular mental health clinic, it was kind of like benzodiazepines just became like something that was just flowing out. And so I'm really grateful to the pharmacist for red flagging several psychiatrists over and over and over again until something was done. So I imagine that there are times when a pharmacist would see really inappropriate prescriptive practices and the doctor would say, just fill the prescription.
Yes, definitely. And there's definitely a friction there for sure, which is, I think contributes to this conversation where, the physicians might not feel as comfortable. They don't like the questioning part sometimes. But what I think that providers don't always understand is that legally, pharmacists have what the DEA calls a corresponding responsibility. So we can't just check mark because you said we have to fill it, right? We do actually have to do our due diligence. And in this case, it's not appropriate. Controlled substances, benzodiazepines, are not first-line therapy for anxiety, right? We really need to go back and look at what are our mainstay medications that we're having patients on. And, yes, sometimes it's appropriate to have benzodiazepines. Certainly they have a place in therapy, but not as a first-line treatment.
And just to bounce back to you talking about the boxes where people could dispose of their medications, the way I learned about this was when I would see patients for the first time and they would bring me this big bottle and they'd be like, hey, I need to get rid of this. Like, I hate the way these make me feel. And like, it was just a bottle that was almost completely full because this patient who'd never taken Xanax before took it like the first 2 times and was like, oh, I hate this.
Yeah.
This sucks. Like, this is not what I want. And so they're handing me this huge bottle back. And so anyway, I guess like in closing, I want to double down on the importance of the bill, that it's about expanding access to care in our state, where we know that there are plenty of almost primary care deserts where folks don't have regular access to primary care, but there might be a pharmacist working in that area who could fill that void. Can you just speak to that?
Yeah, absolutely. And that's definitely where I see us being able to make the most impact. And because it'll help people not have to delay care or have to take time to come travel far to get that care, right? Delays in care, we know, end up costing the health system tremendous amount of money and time, right? And leads to worse health outcomes for patients. So when we're thinking of some of these really simple kinds of things that we can do with the bill, low acuity types of treatments, I mean, we can really help patients get access. And this is stuff pharmacists are already honestly doing a lot of triage for these things. Anyway, I worked in the community pharmacy for a long time. People come up to the pharmacy counter and they're like, oh my gosh, I have this bug bite. Do you have something you can give for me? Or, my kid has this pink eye. Do you have some eye drops I can have? Or I have this rash, right? So they're coming up and they're asking questions. It's like pharmacists are very good at identifying things and basically helping the patient to navigate the next step in the healthcare system, right? With this bill, we would already be required to refer on to a higher level of care if it's something outside of our depth or outside of our scope, which is what we do already anyway. Pharmacists are very comfortable with that.
Well, and I'm going to speak about UTIs really fast because I think most folks assume they have UTI. They need to go in and they need to pee in a cup and find out if they really have one. But that's not really true. What I always say is believe women. Like women know when they have a UTI. So here's the deal. If a woman comes into urgent care where I'm working and she says, it burns really bad and I have to pee all the time, I believe you and you're going to get treated for UTI. The only purpose of you peeing in that cup is for us to do a culture for antibiotic resistance. Like that is literally
absolutely.
that is literally what we want to make sure that, that the antibiotic that we're getting you is going to work. But so that's a long way of saying you could be treating a lot of UTIs. And I know people who are super frustrated about having to go to an urgent care or go to an ER because it's Friday night and I've got a UTI.
Right. I'll actually tell a quick story to end us really quick. So when I was in Washington State, I participated in a study where we had 46 community pharmacies across the state treating minor ailments in the community pharmacy. So what we would do, and UTIs were the most popular by far, right? And I know that some physicians have raised the concern like, oh, well, what if it's complicated? In the assessment, if there's flank pain, if there's, these other things that make it complicated.
Pyelonephritis, this is a very sick person in front of you. They will be sweating. They will be vomiting. In most cases, it's not subtle.
Those people will be passed on to a higher level of care, certainly, right? But that was by far the most common treatment in the minor ailment scheme that we had. And so my role, I was actually a student for part of this. I would call patients after the fact to do follow up with them and ask them questions like, did their condition resolve completely? Mm-hmm. And where would have you gone for care if you weren't able to go to the pharmacy? And what we found with that study was that the outcomes were the same, whether they got treated at the urgent care, the emergency department, or at the pharmacy, right? So same care, same outcomes, right? And the cost was $277 less per episode on average. And
if they got it at the pharmacy.
Yeah, exactly. So besides those outstanding results, the number one thing that really stuck with me in those conversations with those patients is that they said, oh my gosh, this is amazing. I didn't have to take a day off work. I didn't have to drive an hour to the nearest urgent care. I didn't, I saved time in my life, which is amazing. And that is the real value, I think, for Alaskans and the takeaway.
Well, Dr. Seignemartin, thank you so much for being on the show today.
Yes, absolutely. I love being here.
Thank you, listeners. If you like what you heard, please subscribe, rate, and review us. To contact me, email rep.andrew.gray@aklec.gov or call 907-465-4940.